Hi, everybody. My name is Catherine Legault. I'm one of the stroke neurologists at the MNI. I spoke with Audrey in the last few weeks. She wanted to have a neurology talk. I'm super happy to be with you today. I'm going to talk about treatments in stroke, mostly TPA and thrombectomies. I'm going to try to approach also some of the complexities of the emergency room issues that you can have. And I would really, it's a very short talk. It's only 40 minutes. So please, I want to make this as interactive as possible. So please ask your questions. And I also would like to touch a little bit on your feeling about TPA. And I know there's been a lot of controversies between the emergency and the neurology literature. So I would love to hear your thoughts on that. So I'm going to start with a case. This is a typical case we could see at the RVH and the MGH or at the neuro. So it's a case of a stroke in the emergency department. In this case, it's at the Montreal General. So patient is a 72-year-old, presents to the ED. Patient is known for hypertension and hypercholesterolemia. Patient uses a walker in the winter because of imbalance, but otherwise is fully functional. She was with her friend at 5:30 p.m. when she had a sudden onset of surge speech and weakness, and the ambulance was called. And at their arrival at the scene, she was graded a Cincinnati 3-on-3. So for those of you who are not familiar with the Cincinnati scale, it's basically a pre-hospital scaling system that's supposed to identify the likelihood of a patient having a stroke. So it looks at speech, facial palsy, as well as weakness. And basically, if you score 1 in 3 or 2 in 3, you're usually redirected to a secondary stroke center. And if you score a 3-on-3, normally you should be directed either to the MNI and the CHUM in Montreal. So the goal is to get patients with stroke symptoms as fast as possible to a place where they can be receiving treatment. So the goal here is not to send a patient like her to, for example, to La Salle Hospital where they don't have a neurologist or emergency services in terms of neurology. So in arrival in the emergency room, the patient has vital signs, a little bit hypertensive, and atrial fibrillation with a fast ventricular response at 120 beats per minute, acting well on room air. Patient can talk, does not follow command, opens eyes, and is very awake. Patient is looking towards the left side and is not able to move the right side of her body. So this is the CT scan, okay? Let me just close this. So what you can see here, actually, a patient was sent right away to a CT. It's called as a code stroke at arrival. And what you can note here, and this I put these two slices to really kind of give you an idea of how we would calculate what's called an aspect score. So when we have a patient coming into the emerge with acute neurological symptoms, the first thing we always ask for is a CT head. And the goal is to, look for any intracranial pathology. So this is an ideal situation where in her CT head, we actually do not see any asymmetry between the two hemispheres. So she comes in with speech issues as well as right-sided weakness. So obviously we're going to be interested in the left hemisphere here. So as you can see, the cortex needs to be spared on the left side. You can even see some parts of the insular ribbon, which is completely normal. And the subcortical white matter is also preserved. And when we go to the higher slice here up top of the ventricle, again, we can see that the cortex is completely spared over the left side. There's no evidence of early ischemic changes, and there's no evidence of an increase of intracranial hemorrhage. So just a quick review of our big stroke syndrome. So when someone comes into the emerge, when we like to call something a left MC syndrome or a right MC syndrome. So a left MC syndrome means that the patient's going to have right-sided weakness. The gaze deviation is towards the side that's moving. So it's a left gaze deviation. We have a right hemianopsia and we have aphasia. Here, sorry, I should not have said aphasia. Here we have an hemi-neglect syndrome. So on the right MC syndrome, we have left-sided weakness, a right gaze deviation, left hemianopsia, and a very profound neglect syndrome. So I'm sorry about that. The neglect syndrome will manifest as an extreme gaze and head turn, okay? So if you see a patient being wheeled into your emerge with hemiparesis and this type of head turn, usually it means that you're dealing with a large hemispheric type of stroke, and it's very important to act fast in those circumstances. So this would be an example. So this patient is looking towards the left side and the right side is paralyzed. So we would be looking at a left MCA stroke. In a right MCA stroke, here you see it's just the eyes that are deviated. We would expect the whole head to be deviated towards the left side. So in a case like this, where a patient comes in with clear neurological deficits and a normal CT scan and a clear time of onset, usually we will consider this patient for TPA. So a quick history of thrombolysis. So usually in neurology, especially in stroke neurology, we say that we're always 20 years after the cardiologist. So when the cardiologist started to use TPA in 1984, these were the first studies on STEMI. So they started to thrombolyze patients in the mid-80s. It takes about 10 years for neurologists to get their act together, and they finally get the NINS trial on. So this trial will last for a few years in the US. Major switch. I mean, prior to the NINS trial, I mean, you would kind of call the priest when someone had a stroke. There's really not much to be done. They were fussing around with IV heparin versus antiplatelet agents, but nothing was done in acute stroke. So the NINS trial turns out to be positive, and that's where the controversy will come after. And it will take a long time actually to TPA to be used widely in emergency departments. In 2004, finally, there is a level 1A evidence for stroke that is a change in the guidelines. In 2008 comes out the ECAS-3 actually trial, which will increase the TPA up to 4.5 hours for selected patients. And in 2012, the IST-3 trial will come out, which is actually quite recent. So I was in residency when this happened. So this was when we extended stroke TPA treatment to actually all ages. So before that, we would reserve TPA for patients below the age of 80. And now there's no cutoff age limits. And actually the older patients seems to be doing better with TPA. So I'm going to skip this because I don't think that's the point here, but I just wanted to quickly tell you how we calculate outcome in stroke. We look at what's called a modified Rankin scale, okay? So modified Rankin scale is a scale on 6. 6 is death, 0 is no symptoms. What's considered a good outcome in trials is 0, 1, and 2, okay? 3, you start to have issues at home, so you need to be supervised. 4, you have some walking disability, so you either need someone or a cane or a walker. And 5, you're bedridden. Okay, so 0, 1, and 2 are considered good outcome. And if you look at stroke literature, we have an ordinal MRS scale, and this is how we will report outcome. So basically what it does is it shows how many patients are in each categories of MRS and how it changes from treatment to no treatment, basically. All outcomes are calculated at 3 months, okay? So this is very important when we give treatments to stroke patients. And it's to tell the families that, you know, there might not be a miracle recovery because outcomes in studies was calculated at 3 months. And this, why 3 months, is because that's the NINS trial. That's how it was calculated in that. And this is what we've been using since. The other thing about the 3 month thing is that the other thing about the 3 month is that we usually tell patients that most stroke recovery will happen the fastest in the first 3 months after the stroke. Okay, so the bottom line on TPA efficacy, okay, so these are the numbers that you will see floating around, okay? So the number needed to treat is about 10 versus the number needed to harm at 40 for 0 to 3 hours, okay? The number needed to treat goes down if you're in the later stages from 3 to 4.5 hours, so a number needed to treat of 18. And then you really get into issues when we're getting after 4.5 to 6 hours with an NNT of 50. That being said, now we are doing trials to give TPA in the first 24 hours of presentation. So we're moving, so all the TPA and thrombectomy trials were done on time being the main marker of treatment availability for patients. And now we're really moving towards using tissue-based markers. So instead of looking at when the patient is coming into the emerge, is looking at their scan, because not all stroke patients are equal when it comes to their stroke growth. So some patients, like our patients, it's 2 hours within the stroke onset at the time in the emergency room as a completely normal scan. Some other patients have really, really poor collateral flow. So at 2 hours with a blocked artery, their scans look really, really bad. And so now we use advanced imaging like CT perfusion, multi-phase CTAs to describe how each patient's tissue is responding to time. And then we decide on treatments based on that rather than just looking at time. So we will see a lot more patients being eligible after the typical 4.5 hours in the next years. And what's interesting is that now, looking at tissue-based, a lot of patients that we would give TPA for, we might not actually, because we know that their risk profile is much higher. So I'm still giving you the TPA time-based number needed to treat, but just know that probably in the next 5 years, these things will change wildly.
Sorry, Catherine.
Yeah, for sure.
Those numbers, they're based on the NINS and ECAS, or that's like a combination of patients from multiple trials?
It's a combination of patients from multiple trials. And these are kind of like the TPA and number needed to treat that we would quote to neurology residents for exam purposes. Okay. So this is like a composite outcome of the trials. But the specifics of like, you know, did they use the Atlantis 1, 2, and all of those things in the trials? Because there were other TPA trials that were negative, as you know. So I'm quoting the 3 that were positive, but there were other trials that were done that did not show benefit. But the way they were done, they used, again, like this was early 2000 trials. They were not really using appropriate markers for treatment inclusions. And that's why they were negative. So these are the numbers that if you look at any literature, you're going to find those numbers needed to treat. So the time is brain ratio. So I was just telling you that we're going to look at tissue is brain instead of time is brain. But there is definitely a concept that the faster you treat, the better your outcome will be because your neurons are dying quickly as time goes along. So the earlier you get a patient in your emergency room and for treatment, the better it is. Again, that being said, not all patients, we have slow growers, we have fast growers, and it truly depends on the speed at which the patient's stroke is evolving. But overall, we do have, you know, time is brain motto in the back of our mind. So usually what we will try to do is to make sure that if we have a patient in our emergency room, the door to needle time, meaning the presentation to the time where TPA is given, should be less than 30 minutes. Obviously, the more strokes you have in your institution, the better you're going to get at getting those times down. The problem here at the MUHC is that the patients are going, the Cincinnati's 3-on-3s are going to the neuro. Therefore, you're not seeing a lot of acute stroke at the RVH, and you're actually not seeing a lot of acute strokes anymore at the MGH. So a lot of the places are a little bit dusty when it comes to, you know, treating patients fast. And that's why our door to needle times outside of the MNI are not necessarily optimal. I can tell you at the MNI, if we get our ducks into order, it can be 15 minutes from door to needle time. So what do you need to know before giving TPA to a patient? So if you look at the TPA protocol from the MUHC, which we're in the process of changing, there's like a huge list of inclusion and exclusion criteria. The inclusions are actually really short. It's like, are you having a stroke? And the exclusion are super long. So these were copy pasted from the NINS trial as well as the ECAS-3, okay? But the reality is that most stroke neurologists will not use these inclusion exclusion criteria. So what do you actually need to know, okay? You need to still now, we're using time-based, so you need to know that the onset was less than 4.5 hours ago. So unless I'm at the MNI and I know very well what I'm doing, I would not give TPA outside of the treatment window if I don't have multi-phase CTA and a CT perfusion. So I would say that the time-based of 4.5 hours still stands for all our patients. Neurological deficit, that is disabling, and that's a very important thing. If someone shows up with a little facial droop, isolated, and they're able to drink, to talk, and to do all of these things, and they just have a little bit of a facial droop, I might not give them TPA. But if they show up with an arm or hand that's weak, and it's their dominant hand, for example, I'm left-handed, and if my hand doesn't work, this is a disabling stroke. So it really truly depends. Like we use the NIH-SS to calculate the score of how bad the patient is, but I don't look at the score. I look at, is this a disabling deficit for the patient? And that's a really, really important thing. The third thing is the scan normal? Okay, I don't need to see a stroke on the scan. I actually don't want to see anything on the scan. I just want to make sure that there's no blood. So be careful about small subarachnoid blood, little subdurals that you can miss, but we really are looking for big signs of blood on the CT. And you want to see if there's any history of systemic blood. So is the patient having any active hemoptysis or GI bleeds? And that's really important because that to me is a clear contraindication for TPA. So if the patient is describing or the family that they've had, you know, hemoptysis or a little bit of bright red blood per rectum, I'm going to be very, very careful with TPA in this case. And the presence of an anticoagulation use. So being on Coumadin is not a contraindication, but having an INR of above 1.7 is a contraindication. Being on Xarelto, though, and being compliant, to me, that will be a contraindication for TPA, no questions. For the Coumadin, check an INR fast. Again, so a lot of patients come in and their INRs are below 1.7, and these are still TPA candidates, okay? What would I like to know when a patient comes in? I would like to know prior level of functioning. So I want to make sure I'm not giving TPA to someone who's living in an assisted facility, who's a level D of care before coming in. I want to know if there's been surgeries or procedures in the weeks prior to the TPA, okay, being given. That being said, though, if, for example, if you have a stroke and you've had a hip procedure 1 week before, so for example, a hip replacement, I would tell you that I would call the surgeon who's done the procedure and then discuss that directly with this person to see if it's a contraindication or not for TPA. And I would say most of the time, unless it's huge surgery, obviously anything cardiothoracic or liver related, most of the time surgeons will say that it's okay to give TPA and they'll manage the bleeding after. As an emergency doctor, I think that these types of more complex discussion, it's a little bit tougher for you to have. I would leave that to the stroke neurologist to discuss with the surgeons, because it is, I'm telling you about this. It's something we do sometimes, but I would not take the onus on you to have those discussions. I think it's more of a neurologist to surgeon discussion. BP and glucose, obviously, I want to make sure our BP is not too high. Glucose, same thing. If it's super low or super high, it can mimic neurological symptoms. So we want to correct that before giving any type of treatments. And all the other things from that long TPA list, I would like to know about them, but they're not necessarily a true contraindication. So as an emergency doctor in a situation like that, what is expected of you? So in this example of our patient, so the first thing is that you recognize that the patient is having neurological symptoms that are disabling, and to go and assess the patient right away. It's like a code STEMI, basically. It should be kind of taken as the same level of urgency. And I would say that in general, emergency doctors are excellent at doing this. And be inclusive in your emergency evaluation. So we can treat up to 24 hours with thrombectomy. So if the patient is coming in and it's at 8 hours of onset, it's not because it's not necessarily a TPA candidate that we don't want to take this as seriously as a patient coming in at 2 hours. So I would say up to 24 hours, let's consider all the patients to be the same. And ensure rapid imaging. And so this is really easy to do in an emergency. You just ask for a CTA, a stroke protocol, and basically they will image the brain and they'll do a vascular imaging of the arch to vertex, so the whole intracranial and extracranial cervical vessels. And usually that goes very smoothly in the emergency department. But again, be inclusive. Like if you're not sure, it's better to call it than not to call it. What about the TPA consent? So if we decided the patient might be a TPA candidate, who should give consent and how does it work? So normally in most cases, if you work in a place where there's a neurologist, the neurologist will be in charge of, asking these things. But certainly in a place like Valleyfield, for example, where we have a lot of emergency doctors working, but no neurologist, the TPA protocol and consent is usually done before they can have, make sure you assess for trauma. Absolutely. So I can remember mechanism to stop. Okay, these are really good questions. Okay, that was not for me. Okay, with regards to the trauma, absolutely. I'm sorry, I just saw something in the conversé. There is very clear association between face trauma and TPA hemorrhage. Okay, so if a patient has ecchymosis on the face, okay, or any laceration on the face, I'm extremely careful about giving TPA. This comes from the Gusto trial. So this was a trial done in STEMIs, and they've really realized that patients who had facial traumas, it can be associated with complication of TPA. So I would say for me, that's almost like a clear contraindication if they have face trauma. I will try to treat them other ways, but I've done it a few times where like they had laceration and we give them TPA, there's usually a lot of hemorrhage, and be very careful in those cases. That's an excellent point. Sorry, I'm going to go back to TPA consent. So in a place like Valleyfield, where they don't have a neurologist on call, often the TPA will be given before talking to any neurologist. So what you need to know about this is that this is standard of care. Okay, so if a patient is aphasic and you can't reach a family, it's expected that TPA will be given without necessarily getting consent from the family or the patient. Okay. When I ask a patient's family about consent for TPA, I do not drown them in numbers, okay? The most people out there with, most people out there know that the stroke needs to be treated fast and that there's a clot busting medication that can be given. I would say I've never had a family refuse for me to give TPA after I ask them for consent. So what I usually say, okay, is that there's greater benefit than risks, but I will quote them the appropriate number of symptomatic hemorrhage. So this number is about 7% in most patients, okay, fatal in 1 to 2%. And that's what I'm going to quote to most patients. If I have a patient coming in though, who's elderly, okay, who has cognitive issues, I usually quote 10 to 12% of increase of intracranial hemorrhage risk, because I know that those patients are more likely to have intracranial hemorrhage. So usually 7% for most people, with 1 or 2% of fatal hemorrhage, and 12% for elderly patients. But I would say that it's very rarely happened that I've had a family had issues with the TPA. And I usually keep it very, very simple, and I tell them that we have to act fast, and this goes quite smoothly. In the cases where there is an intracranial hemorrhage, you need to have told them that this is a possibility, though. And the intracranial hemorrhage from TPA, they usually will happen in the first 12 hours after the injection. We do see a lot of asymptomatic hemorrhage, and that's very, very easy to deal with. But the bad, like hemorrhages, will happen at the time of TPA or within the hours following. There was something else I wanted to say about this. Okay, I'm going to move on, and I'm going to remember what I wanted to say. I'm sorry. So imaging required in acute stroke. Okay, so when we're going to give TPA, you do not need vascular imaging. TPA, you just need a plain CT, and the plain CT is done to rule out other etiology for the patient's deficit. Okay, it's to rule things. It's not to rule in a stroke. It's to rule out other causes. After you've done your plain CT, then you're going to do a CTA to look for vessel occlusion and vessel abnormalities. So usually we'll get a plain CT, as I mentioned, a CTA of the circle of Willis and cervical imaging here. Okay. So going back to our patient, so the patient gets TPA, and then you're kind of standing at the bedside and you see that there's no clinical change. So back in the days, for thrombectomy, we would have to wait at the bedside to see if the patient improves with TPA and then consider them for thrombectomy. Now we do both things at once, okay? So the limitations of TPA are very clear in acute stroke. So even if you give that to every patient coming in with vessel occlusion, only about, 0% will actually recanalize if the clot is big enough. So we're talking here of a clot of about 8 millimeters and more. They just won't recanalize with TPA. And at the end of the day, it is still a very restrictive portion of patients with acute strokes who will be a candidate for TPA. So usually we quote 10 to 20% of acute stroke patients can get TPA. So it's limited in what we can do. And we can give it to patients who are coming in later, post-op patients, or anticoagulated patients. So usually after we evaluate for a TPA, we look to see if the patient is a candidate for a thrombectomy. And a thrombectomy is much simpler than TPA. What do you need for thrombectomy? You need a reasonably good scan. So you mean a CT scan that does not show a very advanced stroke, and you need a vessel occlusion. And usually that's what you need to consider a patient for thrombectomy. So in our patient, I mentioned she had a left MCA syndrome, and this is her CT. So we see a hyperdense here MCA sign, okay? So this is a clot in the MCA. We see that in some patients with large vessel occlusion, but not in all the vessel with vessel occlusion. Oh, that's a great question. So I'm going to answer this question right away. And then, so do we have patients that say no to TPA and ask for thrombectomies? No, that's never happened to us. Usually we will make that decision for the patient. So there are patients in which I will not give them TPA and I will just offer thrombectomy. We actually recently, trials came out. There was the European, so this is a question, do you always give TPA before the thrombectomy, or would you sometimes just go for the thrombectomy? So it's actually a really complex question, and there are ongoing trials right now to look at that, okay, where we would skip TPA and go directly for the thrombectomy. So there are multiple trials in Europe, in the US, and actually at the European Stroke Conference a few weeks ago, some of those trials came out and said that there was no difference if you TPA. It's not more risky to TPA than thrombectomy or do thrombectomy alone. And somehow this was translated as there's no reason to withhold TPA before doing a thrombectomy. But what I can tell you is that this might be changing in the future. In a setup like the MUHC, if you're at the MGH, okay, and you have a patient who's having an acute stroke and you identified a vessel occlusion, reasonably what will happen is that the patient won't be in the angio suite for another hour and a half if you're lucky, okay? So we will use this model of drip and ship, okay? So in a situation like that, there's no question you should start TPA at the hub site, which is the MGH, before transferring them for the thrombectomy. In a situation where someone shows up at the MNI and literally the CT scan and the angio room are 100 meters apart, and it takes 5 minutes to get the patient from A to B, okay, giving TPA, it's like it's happened to me where I give the TPA and the infusion actually stops after the patient has had their thrombectomy. Like, this is a different equation, okay? But in a situation where you're in a hub site, meaning not at the site where the thrombectomy is done, I would say that TPA should always be considered. Okay, so back to our patient, I'm sorry. So this is a hyperdense MCA sign. And as you can see on the vessel imaging, there's an occlusion here. So this is a normal right M1 segment. And this here, you can see that there's quite a long clot. So I would say at least 10 millimeters of the MCA that's missing, occluded from this clot, okay? This patient was in new AFib. This is probably a cardioembolic phenomenon. And when we see the clot here on the CT, it probably means it's a fresh, very red blood cell dense clot. And these are really the best ones to remove with thrombectomy, okay? So what can we do in thrombectomy? What type of blood vessels can we do? We can do, basically reasonably, we can do the ICA, okay? And usually in the ICA, it's at the level of the bifurcation of the carotids, okay? The internal carotid is often blocked with an M1 occlusion. This is what we call a tandem occlusion. These are ideal candidates for thrombectomies. We usually can do the M1 branch, okay? This branch, like this patient. As soon as this trifurcates in the M2, so the more distal MC branches, if it's a proximal M2, it's usually amenable for thrombectomies. Anything more distal, like a few millimeters or even a centimeter in the M2, usually these we will not be able to do with thrombectomies because the vessels are a little bit too far and they're very fragile and the risk of subarachnoid hemorrhage during the procedure is quite high. So we will see M1, maybe proximal M2s, but distal M2s, it becomes difficult, okay? ACAs, so we will be able to do maybe an A1 segment thrombectomy, but anything after that is going to be too difficult. And in the posterior circulation, we'll be able to do basilar and vertebral, but in PCAs and anything smaller than that, this is not amenable for thrombectomy. Again, things are changing. They're providing new devices where they're going to be able to go in smaller vessels. So, you know, we might be able to be more inclusive in our treatments, but this is what we're doing for now. So the procedure, basically, it's two things. It's an aspiration as well as a stent retriever, okay? So compared to cardiac treatments, we'd never leave a stent behind when we're talking about blood, about the brain, okay? So in cardiac disease, they need to leave stents because these are atherosclerotic lesions. In the brain, they're embolic lesions, okay? So we don't leave a stent behind. The stent is used only as kind of a mesh device to get the clot inside the mesh to retrieve everything together, okay? And so we don't leave stents inside the brain. In some situation, we might do a stent placement at the time of a thrombectomy, but these are exceedingly rare situations. So it's usually two parts. So there's going to be an aspiration guide wire and then a stent retriever, okay, that goes together. We're able to do about 3 passes per clot, okay? So after 3 passes, usually most people will stop, okay, because this means that the clot is not going to come out and the risk of dissecting the vessel is higher, okay? But usually we'll go up to 3 trials per clot. Most of the time, after 3 trials, though, most of the clot is gone. So back in, okay, so about the data behind this, and I think Audrey told me that you guys actually have had the talk on, let me see the time. Oh, okay, I only have 10 minutes. Okay, so the data behind that is that the first trials were definitely negative until 2013, and the New England came out this article saying that thrombectomies for stroke was never going to happen because all the trials were negative, but they were really bad trials, they were bad catheters, bad trials, poor patient selection. Back in 2015 came out about 6 trials for AVT, okay, that were all positive, very, very, very positive. Okay, so this is the data for this is the data from those trials, okay? And here, the TICI-2B or 3, this is the rate of recanalization. So you can see these were the Americans trial, the SWIFT Prime and the Extend IA, and you can see their recanalization rate were amazing. Mr. Clean was the first one. It had about 60% recanalization rate, but I can tell you nowadays, we're usually in the 80s to 90% recanalization, especially with the new stent devices and the aspiration catheters that are being used. Okay, so basically what's different between now and versus 2013 is that we select our patients better. So I mentioned to you that we're using tissue-based selection in terms of instead of time-based. So now we know that a patient like this, for example, don't take them to thrombectomy. There's no point of removing a blood clot when the stroke is so advanced. But a patient like this, though, like our patients, when you don't see the stroke, this is a good target. So we use plain CTs, but we also use perfusion imaging to make those decisions. I won't go into details about that, it gets a little bit, granular, but bottom line is that this is a much stronger treatment than TPA, okay? Then NNT is about 2.6 for any improvement in the functional status, and we're talking about an NNT of 5 to go to an MRS of 0 to 2, meaning patients are able to go back home and live their lives, basically. So very, very powerful treatments. In 2018 came out 2 trials, the Fuse 3 and the Dawn trial. Okay, and I know that you reviewed in your journal club, but what it meant basically is that by using strict patient selection, imaging-based, perfusion-based, we're able to get those treatments to the patient up to 24 hours, okay? So this is our patient. So this is the DSA, so the angiogram. So here we can see that we're missing a full branch of the MCA. So what you see on the angio, this is the ACA, and this is the PCA, and all of this part of the brain is missing perfusion, okay? One pass is done, we're getting the clot out, and all of the MC branches are being recanalized in this situation. So our clinical outcome of the patient, so she got TPA 2.5 hours after symptoms, recanalization was obtained 5.5 hours after symptom onset, and the MRI after this shows a small distal embolic stroke to the left frontal lobe, but the patient has a very, very good outcome. So what are the next steps in terms of stroke treatment? We're going to start using probably TPA in the extended time window, but tenecteplase is actually going to replace TPA. So the first trials came out showing that tenecteplase is much more potent drug than TPA for acute strokes. Still under review, still only 1 trial is out, but it really shows a better recanalization rate. So we're doing some trials at the MNI on tenecteplase, but also internationally. So you probably will see this change in the next 5 years. We're going to use a lot more CT perfusion to extend our treatment window for patients. So not using this 4.5 hours, but really using perfusion-based imaging. But this will be probably reserved to like centers like the CHUM, the MNI, and then we'll probably ask for a lot more patients to be transferred to get these types of imaging, because the reality is that they're quite expensive to, they're about $20,000 per year per site, per CT scan machine. So I'm not sure if we'll ever be able to have all of those at all the sites, but I can tell you the Lakeshore is actually perfusing a CT perfusion. So we're going to be able to work with them to get more patients treated. And thrombectomy is going to be considered for patients with very large core stroke. So patients with advanced stroke, we're seeing that thrombectomy might be actually a potentially beneficial treatments for those patients. So what is the protocol at the MUHC? Okay, so you suspect a stroke, take a deep breath, examine the patient. Be inclusive, color code stroke, okay? This will get you at the bedside a neurology resident or a staff if it's within the daytime, a stat transport, okay? And a spot in the CT scanner right away, okay? And this is true for emergency as well as on the wards or in the ICU. Step 3, let's not waste time. Do a CT plane with a CT of the neck at the same time. So if you're suspecting a stroke, okay, don't waste your time at getting a CT and then getting them back later on for the CTA. We usually have the motto of neurons over nephrons, okay? It's very rare that patients will have, acute kidney failure after a CTA. I would say if you think it's gonna change management and the patient is a candidate for potential thrombectomy, I would do the CT and let's deal with the renal situation after. If a patient is on the edge of dialysis and you think that gets them over and you're not sure if it's going to change management, then, it can be a discussion about the CT, but I would say most times just do it. If you don't know the creat of the patient, don't wait for the creat to order the CT, just do it right away, okay? In case of doubt, you're always welcome to call the stroke neurologist. So the stroke neurologist, where we have a separate call schedule than neurology, okay, we're based at the Montreal Neurological Hospital, and there's always someone on call just for stroke who's a stroke specialist. So our colleagues usually will not give TP at the MGH or actually at the MGH they will, but at the RVH without calling us, but you're welcome to call us as well if you have a specific question. Post-TPA care, what do you need to check? Control blood pressure, okay? My favorite drugs are labetalol and hydralazine, okay? They're easy to manage. If you give them more than 4 doses and the blood pressure is not well controlled, then consider a drip, okay? But usually we can get away with just PRN of those medications. Some patients might need craniectomy if the stroke is very big. If that's the case, the patient anyway should be transferred to the neuro ICU at the MNI. Okay, post-TPA hemorrhage, as I would say, it's usually happens in the first 2-3 hours after the infusion. About 30 minutes after starting the TPA, after stopping the TPA, the half-life is already finished. So the drug is not in their system anymore. So usually we'll see that pretty rapidly. If you see a patient that you gave TPA to that deteriorates, okay, stop the drip, send the patient for a stat CT. What about reversal agent for TPA? So do we, give cryos, platelets, all these things? I would say in most cases, if there is a TPA hemorrhage that's symptomatic, we always throw the kitchen sink at the patient, meaning we give them all the products. Usually it doesn't really help because by that time the TPA is out of the system. But if that happens, I would call the stroke neurologist on call and then we can discuss these things. Antiplatelet and anticoagulation therapy needs to be held for at least 24 hours after the TPA, or at least until the next morning. We will get a CT and then we'll decide on antiplatelet and anticoagulation. So what about the remaining of patients? So as I mentioned, about 6% of patients coming in with stroke will be candidates for intra-arterial treatment. About 21% will be candidate for TPA, but it leaves about, 80% of our stroke patients who will not be candidates for acute stroke treatments. These patients usually will get admitted to our stroke wards, and we will work them up after. But it's still, the acute treatments are still a small percentage of our stroke treatments. Yeah, exactly. What about stroke mimics? So I think your concern, especially for an emergency doctor who might not have the same, neurological expertise as a stroke neurologist, the concern is always, well, if I give TPA to a patient with a disabling stroke and they actually did not have a stroke, like am I potentially doing harm to the patient? So stroke mimics actually represent about 30% of patients presenting to the hospital with acute neurological symptoms that are disabling. So if, strokes are not the only thing that patients come in with. So for example, someone has a seizure at home and they come in, they're hemiplegic because they have a Todd's paresis, or someone comes in and they have a Bell's palsy, but it looks like a facial droop, or someone comes in and they have a pseudo seizure and now they're paralyzed. So it's still pretty common as a clinical presentation. So usually also, when we're talking about stroke, we're asking everybody to do a very quick neurological examination and a very fast history taking before making big decisions on treatments. So, in an acute potential stroke, I'm not going to spend 3 hours examining the patient and getting a clear history to decide if this is a stroke mimic or not a stroke mimics, okay? When we look at it still with our small rapid history taking and clinical examination, it's still pretty good. We're making, these are data from neurological literature, but about 7 to 15% of all patients treated with TPA actually have stroke mimics. So it's still not a big percentage. So common stroke mimic in clinical practice, so migraines with auras, can present with stroke-like symptoms, post-ictal deficits or Todd's paresis, hyperglycemia, hypertensive encephalopathy, reactivation of prior deficits, so someone with a stroke who has a cold who comes in with worsening, motor symptoms, a mass lesion, a tumor, subarachnoid hemorrhage, and a conversion disorder or functional neurological disorder, which is the diagnosis of exclusion. So what are potential, I have 2 minutes, okay. Potential clinical features to recognize stroke mimics. So on history, younger patients, absence of vascular risk factors, prior seizures or prior migraines are telltale sign. On examination, if the patient is not hypertensive, that's usually a sign. A lower NIH, decreased level of alertness. So most stroke patients are still awake with their stroke, so that's a telltale sign. Normal extraocular movements, the presence of seizure-like movements, these are a telltale sign you're dealing with the stroke mimics. Clinical features of a stroke. Okay, and what's the safety of TPA? So for example, if you're not sure if someone has a stroke or a stroke mimics, if you give them TPA anyways, what will happen? So actually there's few studies looking at that, but overall, it seems to be a very safe treatment. So we're talking about less than 1% hemorrhage risk, okay? So if you're not sure if it's a stroke mimic or a stroke, we usually will give the TPA anyways. And we've certainly done that in patients in which we suspected conversion disorder. But if we're not able to get the patient to actually move normally and they really seem to be paralyzed, we usually will be inclusive and give TPA. I think in a situation like that, where with the imaging is normal, there's no vessel occlusion on the CT and you're really not sure, this is a situation in which I would get a neurologist involved right away to make sure that, you feel safe giving the TPA. But if you were to do it and then realize that it was not a stroke, and a stroke mimics, most of the time it's going to be safe. Again, I'm going to go back to the comments of our colleague about trauma, okay, before. This is a situation though, if you're not sure if the patient's having a stroke and there is a trauma history, I would probably withhold from giving TPA because of the risk that you might be missing spinal cord injury and other things like that could be potentially risky. But for just a patient walking in, if you're not sure, TPA is probably a safe treatment. Okay, I'm gonna stop here. Okay, I talked a lot and very fast. I hope things made sense. But